And the next presentation will be about radiology. Radiologist Adomaitienė will talk about MRI diagnosis of locally advanced prostate cancer. So, Afidėja, Lithuania.
Yeah, I'm representing here the biggest company for radiological imaging in Lithuania. It's Afidėja Lietuva. And my talk is about MRI diagnostic of locally and advanced prostate cancer. What we are going to talk today is everything than more than T3 on TNM with the big stress of two extraprostatic extension called EPE. And why EPE is so serious issues for us, it's because no one would like to have a patient with positive surgical margins or biochemical recurrence or metastasis or recurrence after radical prostatectomy. And EPE is our dragon, and we have an epic fight here, and all of us, we all are knights in this fight against dragon. And to know our dragon better, we use T2 sequences on MRI, and we're looking for broad contact between tumor and capsule, to capsule bulging or to invading to rectoprostatic angle or to neurovascular bundles asymmetry or to direct extension to neurovascular bundles or direct extension to seminal vesicles. And of course, the best experts of this dragon are pathologists. With only one remark, pathologists come to take blood from dragon corpse, from dead body. But they are so good that we orient on them, and the histopathologic severity of EPA is strongly correlated with biochemical recurrence-free survival. So that's why we orient on them. But we need to fight the dragon while it's alive, and we have our own weapons in the pocket, and so modalities using for it like MRI, high resolution or micro ultrasound, and in some studies even PSMA, PET, CT or MRI. Different modalities, but MRI is more popular almost on every corner, while micro ultrasound or PSMA, PET MRI is very rare. That's why we are going to talk only about MRI. But MRI for evaluation of EP has well-known limitations and its bad sensitivity, you may see here. And this occurs due to some factors like significant inter-reader variability, lack of standardization, and pathologic EP varies with specific MRI findings, and also we use only qualitative methods so far. What to do with significant inter-reader variability, we heard yesterday through discussion among Mantas and Arturas, and what to do with lack of standardization. I try to explain you now. Pathologic EP has commonly been reported in binary terms, like yes or no, and if yes, how many millimeters. But MRI findings are not so definitive for pathologic EP. And in such cases, it is common to create a likelihood scale that estimates the risk of pathologic EP rather than providing binary answer, which is possibly not so accurate. That's why we will talk about scales and grades, like already known PIRADS or BIRADS and BIRADS and so on. And these grades and scales are our weapons in our pocket. Well-known PIRADS promoted by European Society of Uroradiology, more than a new EP grade by Meralevant and less known Likert EP score. But actually, while all these scores and grades are not in guidelines, every institution might have their own score criteria or grade. So NVE might have their own, and Santaros clinics their own. So nothing so strange or important, and don't be surprised by this picture and the fish on this picture. So even this gray herring fish could be a good weapon, could be a good one if we add a good vinegar or oil to it, and you will understand it at the end of the lecture. But let's start with pirates. Pirates, and it's an old school, it's used already for 10 years old, with some transition from 2012 till nowadays. But surprisingly, this transition in EP criteria going by not upgrading but by downgrading from scoring system to binary system. But some new things appear here too. It's asymmetry of neurovascular bundles and length of interface between tumor and capsule. How does it look in clinical studies and papers? So here is the Cluj-Napoca from Romania. It's the BJ Center in the Eastern Europe. And despite Pirates is the old school, and I wait from it the clear results. Results are not so clear, it's not black and white, it's rather like 50 shades of gray. And you may see differences in sensitivity and specificity. It's due to disagreement among readers. But take a look on negative predictive value, it's quite good. The next one is EP grade, or Meralevant grade, named by the author. And this is already a grading system. They use criteria like linear contact length, capsular irregularity and bulging, and grade 0, no suspicion, nothing. Grade 1, one of these three, long contact or capsular irregularity or bulging. For grade 2, we need both, so long contact and capsular irregularity, or capsular irregularity and bulging, or long length and bulging. And for grade 3, we need direct, visible, and suggesting anatomic structure. In this study, neurovascular symmetry of neurovascular bundles was quite rare thing, so that's why they distracted from this system, and it wasn't implemented. And the obliteration of rectoprostatic angle also was a rare thing, and they excluded it either to maintain this system quite simple. And again, the system as well dependent on observers. And how does it look on studies? Here's a study from Meralevant and company. It's quite a bit better according to sensitivity and specificity. And against histologic finding as a standard of reference, the system achieved 75% of sensitivity and 68% of specificity of EP, grade 1, and even greater in retrospective cohort. And again, take a look on the right column for negative predictive value. It's even better than for pirates. The next one is Likert. Likert is something not so popular and is something more subjective. And it's something alternative, but if you like it, so you're not far from reality too. They use less or more the same criteria, and their grading system looks like that. 1, criteria not present, 2, probably not present, 3 uncertain, 4 probably present, and 5 definitely criteria. And before we are going forward to compare all 3 system, Likert, PIRADS, and EP grade from Relevant, I will address next 2 slides to my colleague radiologists to understand what are we working with, what does it mean PIRAD system, and together for urologists to understand what are we talking about. Actually, PIRAD system was invented not for assessment of certain patient. It was invented for standard reporting and communication among radiologists, among centers, and it's more suitable for clinical studies and for writing papers, but not for definite patient assessment. Actually, working with PIRADS, we assess prostate by Likert, actually. We are not blinded to clinical data. We know PSA, usually we know anamnesis and family history, and if we would like to use raw PIRADS, we should be blind to this data. So do we really use PIRADS in our clinical practice? Perhaps no. We communicate by PIRADS, but we use Likert. And not so everything bad with old school PIRADS. It's better investigated in all kind of problems because it's more suitable for clinical studies. But again, it's PIRADS not applicable to active surveillance or disease recurrence. Of course, for now, we have a proposal grading system for recurrence like PIRR grade, and I'm happy with that. And so just ask a question, raise a question to yourself, what are you working with? And for urologists also take in mind, like PIRADS, it's a tool for communication, but PIRADS not so objective like people think it should be. Comparing Likert EP grade for EP prediction, it is a study with 2 radiologists and 300 patients, and results for EP grade by Relevant quite good for sensitivity, but moderate for specificity. And for EP-Likert scale, results moderate for both sensitivity and specificity. And if we would like to compare all 3 systems, we should take a look on Kijin Park paper. They compare all 3, Likert, PIRADS, and EP grade. And the results are like EP grade has better sensitivity, and EP grade showed a higher positive correlation with histopathologic EP than both other, PIRADS and Likert. And actually PIRADS shows the weakest agreement between readers. And if we would like to express it in more simple way, so with the little differences, EP grade is the best one, then Likert, and then old good PIRADS. But all things were told about. It's everything about weapons of radiologists. But what about urologists? They also may add something from their side. And I'm talking about nomograms and clinical variabilities for risk prediction. And Relevant with his team made this study. They add to EP grade or just separate MRI clinical apparate features some clinical variables, and some pathological variables from International Society of Urological Pathology from biopsies. And after that, their curves look better. The yellow one is just clinical predictive models. The blue one with dots is separate epigrade MRI model, and all others, red and violet, combination of epigrade and clinical factors, or just separate MRI features with clinical factors. So two different weapons better than one. And another one study, and this Merelevant study is quite a big one, so it's from 3 big centers like Mainz, Bethesda, and Rockville. And the next one also from very known, very good center from Heidelberg, from Schlemmer. They made totally the same thing. They combined clinical parameters with MRI, kind of clinical models and risk stratification systems and nomograms. And again, combined curves looks better than separate curves for just risk stratification based on clinical data or MRI data alone. I would like to finish with two different points of view to this epic battle. The first one, what if the weapons arsenal is not right? What if the MRI is not the right tool? Here's the study from 2022, and here compared micro ultrasound with MRI and against prostate histopathology after prostate resection. And they used 4 predictors for ultrasounds like capsular bulging, visible breach of the prostate capsule, presence of hypoechoic gallo, and obliteration of vesical prostatic angle. And the ability to predict for one predictor, it's 44%, and for 4 predictors, ability to predict EPE is more than 90%. So I do not advocate to replace, just in case if you have opportunity to reach a micro ultrasound. Of course, it's not on every corner, but just use it as well. And another, what if we use our swords for shooting instead of cutting and chopping? We were talking only about qualitative MRI features, but what about quantitative assessment? And here's the attempt of Lee. It's a meta-analysis of 2021, and length of capsular contact, ADC, tumor size, and tumor volume showed moderate to high diagnostic performance of predicting EP. But however, the optimal cutoff threshold varied widely among studies and needs further investigation to establish. So future will show us which direction towards we will move. And take-home points. The first one for radiologist. Every grading system you use is good enough. Is it PIRADS? Is it Merelevant epigrade or Likert score? Or is it your own one? It is enough. I think during next 1 or 2 years, we will have some news in guidelines, and one of this grading system will be implemented in guidelines, and life will be a bit easier then. And the second message for urologists, take your allies with you, use 2 weapons instead of 1, and the result will be even better. So bring your allies for the epic battle, Do not rely on MRI alone. Do not rely on one weapon. Take alloys with you and take their swords, arcs, arbalets, bows, and whatever in their pockets. And the goal of this fight is the man in his old ages without inconscience and impotence. And these men are on a high demand in our age society. And we are all knights in this battle. We are allies with our modern weapons, and with help of radiomics, we will bring joy in life of these aged men. So thank you. If you have questions, you may ask now, or I'm available through email.
Thank you for the presentation. Interesting presentation, informative presentation, and beautiful presentation. So any questions maybe from the audience? We have one question.
Thank you, Dr. Irina, for your very interesting presentation and the scores. I want to ask, because you work also in a private clinic, what usually scores do you use there? And what is your practical point? How do you communicate with urologist? Do you have some difficulties to get feedback? What was found? For example, when you find some lesion and you score it, do you have some possibilities to get to the clinical information and to communicate with urologist?
Thank you for your question. I think in Lithuania, and I hope in most European countries, we are fixed to PIRAT system. And for EP, again, we use PIRATs. Personally, me as well, and colleagues as well too. But I expect what we will switch to one of the grading system, and I expect that it will be not Likert due to some circumstances. I think it will be EP grade system, but still we are waiting that it should be included in guidelines. About relationships with urologists and this back information. I work in two clinics, in Afidea and in Santaros clinics as well. It's a pity I'm not a part of urogenital radiologist in Santaros clinics, but so far I have a possibility to check histologies or multidisciplinary comments, results, their decisions. Yeah.
Thank you for the answer. Thank you very much.